Thanks very much, Chairman, and thank you to this panel. We don't have as much rural going on in Rhode Island as many of these states, but I very much appreciate the work that you all have done. And I'm particularly interested in what Dr. Herman, you think about the ACO model. I worked very hard to get that into the Obamacare bill. I have been a harasser and shepherd of it as CMS people have tried various, I thought, not particularly helpful things to strip revenues out of ACOs as soon as they get them and set the new standard low so that you're competing against yourself in ways that are ultimately fruitless. And I'd love to hear from you if there's anything that you think is immediate that would help advance the ACO program, and to the extent you want to reflect on it, if you could take that as a question for the record, because I'm eager to spread ACO incentives as broadly as possible and to try to make sure that in Rhode Island we had 2 spectacular ACOs. I mean, killer. They were just fabulous. They made a ton of money for Medicare. Their patients just love them. So I've seen it at its best, and I want to make sure that that gets
we are strong proponents and strong practitioners of value-based care in the ACO model. We were probably one of the only level 3 ACOs in rural America. We believe it's the best way to care for patients. I agree that when you look at the Medicare Shared Savings Program, my colleague Dr. Holmes is a mathematician, but if you integrate that over time with the model with the Shared Savings Program, somewhere along the line you're giving perfect care free. So the question becomes, what's the floor on that, and what's a reasonable amount to do that? There are many different ways to set up these programs. I think a lot of the programs are set up without the knowledge of the people that they serve, particularly from the regulatory side. And what I would suggest is that you partner with people that want to do it, have a commitment to do it, and do it well, and see how they do it. And then work with colleagues like Dr. Holm and Ms. Rich and Ms. Ani, who are really committed to providing great care for their patients, because it is a great model, not just in rural America, but any place in America, because it takes really 3 things. You know who your patients are, you know what they need, and then you can get it to them before they really need it. That promotes health, wellness, and well-being, and it also decreases the cost of care.
Well, I still have scars from years of engagement with CMS on this subject, and I hope they have a few too. And I think we've learned to respect one another, and I would love to work with you going forward. So let's stay on this.
Perfect, thank you.
Ms. Rich, you are in the Maryland Primary Care Program, which is a statewide program that we don't have. I think it's unique to Maryland. So I'd really like to get your take on how that works. One of the things that I think bedevils the healthcare system we've talked about is the burden of prior authorizations, claims denials, payment delays, the payment warfare that takes place between payers and providers, which at the end of the day I think is a net loss to the system. It doesn't actually add value. If it does, it's negligible, but I think it's actually negative. It just eats up cost and time and effort. Once you go to the Maryland model and you get away from fee-for-service, which I think encourages those kinds of behavior, have you seen that architecture of obstruction diminish in your company or in the state generally?
Well, so I want to start out by saying the Maryland Primary Care Program certainly is under the Maryland Total Cost of Care model that really focused in on hospitals. And so primary care components came in about 2019 and following the community health centers. Chop Tank just joined the Maryland Primary Care Program in January, so I don't.
So you're still in the beginning process.
We are. So I don't have a lot of experience to speak to it, but I'm very excited about the transformation that it'll be doing in our health center to provide greater access to services to wrap around our patients and work on healthier outcomes as a whole.
Well, to me, it stands to reason, and I've got 30 seconds left, so let me make this a question for the record to any of you who care to engage. It strikes me that this whole claims denial measures, claims pursuit countermeasures, that whole back and forth is completely unhelpful and very expensive and ultimately, I think, bad for patients. And to the extent that we can get off of the fee-for-service model that encourages it, I think that's likely to diminish, which will be good for the cost in the system, good for patients, good for providers, good for everybody. So if anybody has observations on that point, in addition to what we should do to help ACOs, I'm all ears, and I look forward to hearing from you. Thank you.
Senator Whitehouse, let me just point out the Maryland total cost of care model is really